So we're on week 9. So we're almost there. This week, we're doing exam reviews. I do mine on Thursday at 2 o'clock. Some people that I have been tutoring requested that time, so that's where I put it for them. Of course, it will be recorded and it will be put on my YouTube channel pretty quickly. I mean, if you want to go and start studying, remember, my YouTube channel has last quarters and there's minor changes in it. Okay, so you can start studying for that exam right now. Anybody who's close to that 78, please meet with me before the exam. Let me hit you with questions. Let me hit you with concepts. Are you understanding them? Do you can look at a question and figure it out? So again, exam 3 can be hard. It can be tricky. So make sure you look at the study guide and you've got your cahoots. Those are your things you need to look at. And if you are going through the PowerPoints, there's some interesting things there too. But the biggest thing is your study guide and your cahoots. Look at them. And of course, anything you don't understand, refer back to the book. This week, not much due for you, so it's a good catch-up week. It is a dosage calculation and a discussion question. I did not get to last week's discussion questions yet. I was sick yesterday. Actually, I spent about 18 hours in bed. My daughter gave me a lovely GI bug at her baby shower, and me and my husband were, running for the bathroom first. But, well, we're feeling a little bit better. I got a little bit of fluids in me today, so I'm here to teach you tonight. So give me a chance. I'll get those discussion questions done for you. Exam is next week. Okay, so anybody, please see me. So let's go ahead. We're going to be doing children with musculoskeletal, articular, and neuromuscular dysfunction. So what are we going to be talking about tonight? Let's look at our PowerPoint. So all of these little pictures depict something. And I love using pictures because I think they tell 1,000 words in a little story there, don't they? So we're going to be looking at casts and crutches. That upper right one is called a Pavlik harness. That's used for hip dysplasia on newborns, and it works well. And then the one on the bottom left is called Buck's traction. We use that in the elderly for fractured hips, but we use that a lot for fractured femurs with children. And then look at the spica cast down there on that bottom right. That's where if the Pavlik harness doesn't work, we're going to go further and probably put a spica cast on. And you can see just the perineal areas out, to void and to move their bowels, but trying to keep that clean. Can you imagine? Now, children, you think that they're not going to be immobile like adults. Now, children can get extremely ill. They could be born with it or it could be a progressive degeneration type condition, okay? Congenital defects, immobilized child. That could be a child with CP. That could be a child with some sort of neuromuscular something. We're going to go into that. It could be something called osteogenesis imperfecta, which is a brittle bone. That's a child that's not going to be that very mobile. Remember, there's always injuries of some sort, infections, and then we know there are times children are sick for prolonged periods of time for whatever reason, whether they're accidents, whether it's overwhelming sepsis, prolonged surgeries, something, but children can be in hospitals for long times. Now, what happens? Well, it's the same as adults. There's no difference. They're still going to have problems with muscle strength and atrophy. So good range of motion has to be done if we can. The skeletal system, all about demineralization and calcium. Well, isn't that all about nutrition? Nutrition. That's why many children, if they can't eat, they'll put a tube feed in because you're getting all that nutrition and they don't have to go through all the energy of eating. And then, of course, you worry about your heart, lungs, and that's all about your lungs being collapsed, not breathing properly, deep breathing, coughing. This also has to do with swelling and blood clots and all of that, and being careful with it and being aware that these are side effects that can happen. Now, those are the things that can happen, but what about the child? children who have to be on prolonged hospitalizations, sometimes it gets like apathetic. Like you walk in the room and they could be angry, yelling, being demanding, or they could just totally regress and be quiet and start sucking their thumb again as in regression. You don't know what a child like this is going to be like. And as nurses, be prepared. Can you imagine a family with a child in a hospital and let's say it's for 6 months? And that's not, being exaggerating at all. We have some newborn children that are so sick it takes 6, 9 months to go home, depending on, what's gone on with them. The family, the other children, all of everybody is all disrupted from that. Mommy has to go to the hospital. Daddy has to stay home with the other children. Oh, they didn't get to that rehearsal or that, class trip because, their brother, their sister is in the hospital. So all of these things are going on at the same time. So I can't even imagine these parents and what they go through. Now, I've seen them, parents come in angry, upset. But I think that it's us as nurses letting them talk, getting them into some sort of groups. There are in many hospitals, especially where I worked, the pediatric hospital, every unit had these monthly family groups, cardiac, newborn ICU, respiratory, neuro, cancer, and they had families that talked about what was going on. And then, of course, there's always individual. So let's go into these injuries now. These are your muscular, skeletal, articular. And these are things that happen because they're kids. They fall down, they play sports, they hurt. Contusion, a bruise, no big deal, right? Well, you got to be careful. Sometimes that bruise goes so deep and it occludes blood flow. So, crush injuries looks like a little bruise. Make sure you're always checking neurovascular signs. So, big concept muscular skeletal problems, neurovascular signs. Is there blood flow going distally to where that's going? Big concept there. Now, dislocation, I see dislocation and I immediately think of the Downs child that can take their both feet, put them behind their head, and, they are so flexible. Problem with those sort of things is hips can pop out. We got to be careful, having these children do that sort of thing. The other dislocation I think of a lot is that nursemaid elbow. Ever have a little child come and their arm is hanging down by their side? They fell off a handlebar, a monkey bar, or daddy was with the arms and pushing them around and playing with them. And all of a sudden, that elbow popped. And now that arm is hanging down to the side. Well, it's a nursemaid. What we do is we just pop it back in, put them in a sling, some Tylenol for pain, and they do really well. But we can't like sling them around on their arms anymore, right? So a sprain. This is jumping up, taking and spiking a volleyball, coming down and right on the ankle. That's what I used to do. I remember multiple strains, sliding into third base, and that ankle gets caught and it's, being sprained. It's that stretch, it's a crunch, it's an immediately swelling, and it hurts. Okay. Strains. This is when you do something repetitively. I know the one time I had a bad strain is I was wearing clogs in an airport and I was going from the first place where the planes come. I had to go to number 54 and had to go there in 10 minutes and I had to run on these clogs in the feet and then the fronts of my legs from all of that. It was at least a mile I had to walk. It was in Dallas, and it was very painful. The fronts of my legs were all swollen, and of course, it just takes rest for it to cure. Now, you're playing volleyball, you come down and you crunch your ankle, and you can hear it rip, and you can feel it start to swell. How do you treat it? Well, first of all, stop, sit, rest, and then ice as soon as you can. Ice decreases the swelling because it makes the vessels constrict, okay? And then get an ace bandage on there, wrap it up so it can't swell, and then put it up in the air. I know the one thing I used to do is sit right down off the sidelines, put my foot right up in the air, and wait for the coach to come to give me ice and an ace bandage because I know that if I left it down, it was going to swell more and it was going to be hurting more. Years ago, we didn't put casts on strains and sprains. We do now. We found that that mobilization helps better. Now, fractures. The most common are kids fall, and what do? They put their hands out and they break their wrists. It could be radial, ulnar, or it could be both. It could be one arm. I've seen both arms fractured bilateral wrists. I've seen it in children. I saw it when the hoverboards first came out to town a couple of years back, and they didn't know how to use them. I had two kids come in with bilateral fractured wrists. Now, in infants, I've told you their bones are soft and pliable. If you see any fracture in an infant, something's wrong. It shouldn't be. I mean, I've seen one fracture of an infant who was a 3-month-old who came in with a fractured skull and didn't look right, didn't feel right. So I went to my charge nurse and I went to the physician in charge and I said, this child, when I picked him up and my hand, I felt like soft, squishy in his skull. I believe this little 3-month-old infant has a fractured head. So what I did, the doctor said, take the child over immediately for an x-ray, stay with the child, and if it is a fracture, do a body x-ray. Remember, infants can fit on a whole x-ray film. And in this, what did I find? I found a fractured femur, fractured ribs, a right fractured humor. And then the head had a displaced fracture behind the left ear. And what is our job when we suspect abuse? Report it. Okay. Now, the mommy brought this baby in, and it wasn't the mother, it was another member of the family. But the child is safe today. And that's what our job is. I will never forget it. Whenever I think of it, I just want to cry for that poor little child. But I did my job, and we did get this child in a safe area. We know bikes are that big thing in kids and sports, which causes injuries. Now, types of fractures. Well, the simple one is what we get: fall down, breaks, and the skin is closed, and then we just put a cast and make sure the bones are lined up. Now, I think the most one that we need to be concerned about is the open or compound. So you fractured, let's say, your leg, and the bone is sticking out. The skin has an abrasion and a laceration, and you can see the bone. What is our priority? Well, it's the antibiotics. Yes, as long as the neurovascular signs are good, good blood flow. It's not fixing the bone yet. It's making sure that we don't let that bone turn into osteomyelitis. So getting those IV antibiotics, of course, a cast, surgery, whatever else they need. Yes, medicating for pain, but it's the antibiotics is are important. There's other sort of fractures where there's splinters of bones in the body, be off of a rib, and now it's floating around in the chest. It could be comminuted. Again, tiny little pieces. It fractures, and there's little tiny little sharp pieces, and now they're like causing a lot of pain. That one hurts. And then there's something called an avulsion. The bone comes away from the tendon or ligament, and now you don't have movement. The one fracture that we're the most concerned about in children is a growth plate. What does that mean? Well, in the elbows, at the ends of the bone, is the bones get bigger and longer and helps the child grow. The arms, the legs, the fingers, the toes, the everything. And it's at the growth plate where they grow. So you can see the pictures of the types of growth plates. We want them lined up. If we have a fracture, and a lot of them are in elbows, I want to tell you, fall down, monkey bars, and the elbow on the ground, growth plate fracture. This child will definitely go to the OR for an open reduction internal fixation. And why don't we just fix it, put a cast on it? Well, what if it's crooked? That child is going to have irregular growth of that growth plate. So it could be shorter, longer, crooked, and it's not going to be equal. I mean, the legs is the most important part, but you want to have good full use of your arms too, right? So growth plate is what you need to know, that it needs surgery, and that's probably the hardest fracture a child could have. Now let's look at bone healing in children. Neonatal period. This is the first 28 days of life. If a bone is broken, we can get it healed in 2 to 3 weeks. Now, what bone would be broken on a neonatal? Well, many times clavicles on the way out of the birth canal. They were fractured, right? Sometimes you might have club feet, right? They're this way, that way, the other way, and you put a cast on them. We can get them remolded into where you want them quick, because they do mold really quickly. I mean, up into children, usually they're in a cast 4 to 6 weeks, and usually they're out. Now, look at adolescents, 8 to 12 weeks. Me, probably is going to be 16, 20 weeks, because older and your body doesn't heal as quick as the younger. So knowing that the infants have the best chance of healing, the quicker we treat things that need to be treated, we're going to get them in the right condition, and they're not going to be crooked, and we could get very good outcomes quick. So you get a child come in, and they're telling you their right elbow hurts. You look at it. How did it happen? They tell you all about it. You look at it, check neurovasculars, right? You do all of that, and you do an x-ray. Now, one of the things that you can tell almost immediately, if a child has a fracture somewhere on a leg, they're not going to put weight on it. It's just if it's a sprain, they'll put their toe down usually, or maybe heel down. But if they're not putting weight on it, you can almost be guaranteed that's going to be a fracture on that child. So what is our goal in anything with a fracture? Well, I think you've heard that with the growth plate. We want to restore function and prevent the deformities, right? And we want to make sure that that child can be able to be moving it, and total function when this fracture is all healed. So the 6 P's for assessment of fractures. So it's pain and point of tenderness. Pallor, which means blood supply. It should be pink, should be good capillary refill. Pulselessness, no blood is going, no pulse, and you're going to see that arm to the bottom right. Now that's an extreme case, but I'm showing you, if a child puts a cast on, doesn't have blood supply, and then doesn't come back for a month, that could happen. Yes, it's extreme, but I'm just showing you it can happen. Paresthesia. What if that cast is too tight, squeezing the blood? That means you're going to feel like numbness in the fingertips. It shouldn't be. You're going into compartmental syndrome now. And then, of course, paralysis. I can't move. And then you feel pressure. You feel that swelling going on in there. So those are your 6 P's. You need to know what they are. Casting for fractures. Well, in pediatrics, most of them hospitals have pediatric orthotechs, and they're taught how to take care of all age children. And what's pretty neat about these techs is they, in many pediatric hospitals, are going to have different colored casting material. You take your child to an adult hospital, you're going to get a white cast. If you take them to a children's hospital, you can come out with pink and green and watermelon, or you can have the colors of your favorite sports team, or it's Christmas, green and red, orange, Halloween, and we do those things and we put them on there. So you get your cast on, and now the kid's okay with it because the color's cool. Now he thinks he's a cool kid. All right, I can deal with it. Now you got to work with cast care. The one thing we need to prevent is it from getting wet. I'll tell you about a little boy who had a fracture on his arm. and went and got a cast, went home, put his bathing suit on, and jumped immediately into the pool with his cast. I think he was 6 or 7 years old. The mother came right back and had to get a new cast on. Well, he did it the next day. So I saw him 2 days in a row with a wet cast. The mother wanted to, she was out of her mind with this child keep jumping into the pool. So we sat with them. We showed them plastic bags. And there are different sort of appliances that we have that are plastic, short arm, short leg, long leg, different size child, small, medium, large. So we them stuff to be able to take showers. I mean, an arm in the swimming pool, if the arm stays up, but that's debatable because we want to keep it wet, right? Another thing, as these casts are drying, they get a little warm. So we need to keep it elevated and we need to keep ice on it. And it's going to start to itch. And many children want to stick hangers and stuff down it. And we should never allow that because a scratch can form, get infected, and that's the end of that. They say a nice, cool air dryer, just blowing that air in there gives them that comfort that they do need. Now, sometimes we don't need a cast, we need traction. What does traction do? And think about traction, it's usually on the lower legs. Buck's traction, big, common. Buck's Bryant are the two ones that we mostly use. Buck's traction is the one that's depicted right here. And what it does, it's used for a fractured femur. Now, fractured femurs, when they're broken completely, the muscles pull and they can displace. Can you imagine it's displacing and now all of those little splinters are hitting all of the muscles and nerves and causing severe spasming and pain. This traction pulls it and approximates the edges now. So now we don't have all of that irritation of all those little bits and pieces of broken bone. So it's a great thing to use in preparation of going for surgery later on. So what does this do? Now there's all sorts of traction. Now there is, as I said, the one for a fractured femur. Now that one to the bottom left, I had a little boy who came into me, little boy, 15 years old, slid into third base, and his head and the defender hit him right on the knee. And everybody heard a crack. And he was air rescued into my hospital. I was the primary nurse on, and he had a C5, C6 angulated fracture. So cervical, it looked like a TP. It should be straight. The lineup of bones, it was crooked. What did I see in my assessment? So remember, they come on the helicopter. They come down to my trauma room. They're on a backboard, neck brace, taped to this, and put on the stretcher next to me. 16, 15, 16-year-old boy. And he was scared. My job. I talked with him and talked them all down, which meant told him what was going to happen. And of course, everybody comes rushing in. It's a trauma. So I let him know what was happening. He had no feeling in his right lower leg. He had a little bit in the left. And this child needed to have an MRI from the ER. We don't do them normally. But he was so severe and all of this neurological deficit, I took him to the MRI. Now, nurses function. When you have a child who could be paralyzed, very close to being paralyzed, you were taking them and moving them from stretcher, bed to the MRI table. Who's going to be in charge? Oh, I was. You're not moving, not touching. The head is mine. You're going to move on my count. And I was very loud about it. We got it done. We got him up to the newborn, to the PD ICU. We placed him on a cooling blanket. We gave him sedation because it's cold, right? And pain medicine. And we put him on that traction that you see right down there on the bottom left. The day later, he had surgery. They put a plate in. I saw him 2 weeks later. He was going to rehab. He had a little bit of residual right leg weakness, but that was it. He was going to be okay. Well, I'll tell you another story. A year later, that little boy came in one weekend and gave me a hug and told me thank you for being so good that he wasn't scared when he was in the ER, and he jumped up and down and was playing baseball again, and life was good. And it was because I monitored his head, right? Nursing makes a big deal here. This is where you shine, where you can make sure the outcome is what you really want it to be. So the types of traction. Now I've mentioned we've already seen the halo, the head. We've seen the buck, which is fractured femur. Now, Stills just has another piece on it, but it's like a buck's. So we treat it about the same. And the other one that I was talking to you about is Bryant's. So we've seen that pavlicarnis and we've seen the spicacast. Sometimes in between that, we put them in Bryant's traction. And it's used for the hip dislocation again. And those hips are slightly up, and it keeps those bones hopefully in that hip socket, and that hopefully that they'll go back to where it needs to be and don't need surgery. So sometimes we have to put these open reduction and external fixation devices on. I think these pictures are great. And what is it showing you? There are times where one leg is shorter than the other, one arm shorter than the other. And we could take and break a bone, put this device on it, and we can separate them and we can get them growing an inch or two more than they would have. That means they're not going to limp if they have legs that are unequal, right? So, what is your nursing care of an external device? Well, look at all those pins sticking in that skin. It's all about doing good pin care, monitoring for infection, neurovascular signs. Now, sometimes infants are born that don't have a lower leg, or don't have a bone in the lower leg, or don't have the leg at all, right? This is things that can happen. What they have to do is to do something to have that child to have the ability to be mobile, right? I had a friend whose daughter was born without a fibula. I had a tibula, but not a fibula, which meant there was nothing they could do. They had to do a below the knee amputation. I met that little girl at 5 years old, and she met my kids. And the day that we met her, this little girl was running up and down the stairs with her prosthesis, chasing my children, ready to beat them over the head. Having an amputation was just fun for her. And my kids and her played like there was nothing going on. Can you imagine? She with her, I'm like, I'm going to beat him over the head. I'm like, no, I don't think you should beat him over the head. Be nice with that. But it was nice to see how ambulatory she was. Sports participation and injury. Well, we know sports cause it, a lot of injuries, but we know sports are important for children. They love the competition as long as they have that support behind, when they need that extra hug if they lose or whatever, right? It's great, it's good contact, but again, wearing the proper equipment and preventing those overload injuries. So overuse. Think about that athlete, that gymnast who's doing the same things over and over and over again. These do cause those overuse strains and sprains and overuse things. So I've mentioned them a couple times already. I've mentioned the developmental dysplasia of a hip. This is also the pavlicarnis. This is hip dysplasia. Girls more than boys. How would you know your baby was born and the socket wasn't where it should be? The femur ball joint, it's not in the socket the way it should. Usually in these hip dysplasia, it's up. So if the hip socket, the femur socket is out of the hip, up and out here, that leg is going to be short. That's the first thing. Number two, if you turn them over, the buttocks, their gluteal folds. One will be up, one will be down. You're also going to hear clicking. That you have positive Ortolani and positive Barlow. First visit with a pediatrician, all infants. One thing that the the pediatrician's going to do is take the knees, put them up and down and back and forth, try to see are the hips the way that they should. Because if not, remember that first 28 days of life, they really heal quickly. So the sooner we get that harness on, the sooner we can get the hip back in joint. So have the harness, very important term, abduction of the hip. It keeps it where it needs to be still so that it can heal. Now, after that Pavlik harness and it doesn't work, as I said, they might go into either, the Bryant traction, or they might need to be placed in that spica cast that I showed you the picture of. Now, if we let it go too much, too far, these children, those tendons get tight like cement, they don't move, and we have to release them. We cut them. And that will help keep that, try to get those legs mobile the way they should be. But most of the time, we can do it a lot earlier. I mentioned clubfoot already. No, you don't have to know all the names. You just have to know club feet in, out, up, down, anywhere deformed. They're not sitting the way that they should be. That's club feet. So what do we have to do for club feet? Well, remember, they heal really quick. Their bones heal really quick when they're a neonate. First 28 days of life. So what do? Well, we have found out is the best type of treatment is using serial casting or Ponseti method. These are casts that are placed on the leg of a clubfoot baby, and it's changed every week. Remember, they heal quick. Every week, it must be checked. As they get older, they must get their feet checked at least once a year from a podiatrist to make sure that we keep the feet the way that they should be. Now, OI, osteogenesis imperfecta, I've seen only one case, believe it or not, in all my career. And it was quite a severe little case of this little baby. The baby was born with brittle bone disease. And sometimes you pick them up and you can hear crunches. I mean, even being the tenderest, carefulest person, I used to only use the baby blankets to pick them up so my hands and fingers wouldn't have to touch or crunch anything. There's no cure. It's more supportive. Um, they do give different therapies, but these children, most of them end up in wheelchairs because of the amount of fractures they've had, which creates all of these deformities. Okay. These children, seeing them in the hospital, these kids would be in their wheelchairs. They get electric wheelchairs. And all of a sudden you'd hear this beep, beep, beep behind you. And you look and there'd be one of these kids going, they're trying to get to the cafeteria. It just opened or something, and it was neat to think that here they are, young kids. They are in wheelchairs and they're so mobile and they were able to go get their bag of chips or whatever they were looking for. Now, late calf birth disease. This is the hip, the head of the hip, gets an infection, but it's called not an infection. It stops blood supply from going to the head of the femur. It's aseptic, which means there's no opening, there's no hole. It just all of a sudden the head of the femur just starts to die. The blood supply goes away. All of a sudden you'll see a kid that will be starting to limp and you're like, what's going on here? So what we do is we put these children on bed rest. And sometimes we even put them on Buck's traction to hold it, right? But these children, our goal is for that head of the femur not to die too bad. So if we rest, no weight bearing. For pain, it's just going to be NSAIDs. They work that anti-inflammatory. And maybe, as I said, that Buck's traction. And again, nutrition. You've got a child where their bones are not working. So good calcium, good vitamin, good nutrition. Now I'm going to go over 3 type of spine abnormalities. Now, kyphosis is humpback. This is where your thoracic spine goes over and you lean over. And you see the older ladies, walking over. It's because, maybe poor posture or whatever, but it's called kyphosis. Now, lordosis is something where the lumbar spine curves in. So you sort of lean back. And these children end up, they're a little bit heavier, so it pulls them. And it's the lumbar spine. That's what you just need to know. Scoliosis. This is the S-shaped curvature of a spine. We see this a lot. It becomes more evident when children go through that pre-adolescent growth spurt between 12 to 14, where they grow about 25% of their height. All of a sudden, you start to see the curving going on, S-shaped curve. And what do you see is you'll see all of a sudden their arm hanging down. You'll see them one hip higher than the other. And what do we do? Well, hopefully, all we'll need to do with these children is to put them on braces 23 hours a day, 1 hour a day off to bathe. That's it. A cotton shirt underneath and this brace on top of it. Now, there are curvatures that are very bad. It's really curved. Those ones, you cannot put them in any sort of brace like that. It's not going to work. It's going to need surgery. And what they call it is Harrington or Luque rods. They take metal on each side of the spine and attach it to the spine, trying to make it as straight as possible. I mean, it's still going to have a curve. You can't get all of it out, but you're going to have some of it out. So greater than 40, greater than 50. I mean, when you see big numbers, that needs surgery. Before that, just good old physical therapy, strengthening the core muscles, and bracing works. Now, we've mentioned osteomyelitis, could be for many reasons. But the thing with osteomyelitis is an infection of the bone, and it's really serious. It's you'll start all of a sudden with these really bad pains, fever, chills, and then the area where you see it. And kids, a lot, it's the bottom of their feet. They step on something. So they get osteomyelitis of the big toe. I've seen that more than once. And what we'll do is look at it. It's red, it's swollen, it's painful. Yes, there looks like an abrasion there. Let's do an x-ray. You may or may not see fuzziness on the bone, may or may not. But you're going to do a CBC. There's an infection. So you're going to see increased white blood cells or leukocytosis. And if there's a hole there, if we can, we're going to get a culture. Again, most of the time it is staph, but you don't try to guess because these are bones. And we want to make sure that we are treating it properly. So what do we see with osteomyelitis? This is like a similar to your rheumatic fever or acute glomerulonephritis. It's you need long-term antibiotics, which is vigorous IV antibiotics for extended periods. This is 3 to 4 weeks, could be months. Trying to clear it up. It all depends. So remember, when we're working with osteomyelitis, it's usually staph, and we're usually giving those aminoglycosides to these children. Those are the medicines like vancomycin that need peak and troughs to make sure that we're not overdosing. These medications cause hearing loss and kidney damage. So what are we going to be monitoring closely? Well, we're going to be monitoring, of course, their CBC. Does the white count come down? Kidneys, the renal, because that's the way you excrete. And then liver. This is, where the metabolism goes on. And we're going to be monitoring that also. Again, as I said, complete bed rest, pain management, NSAIDs if all possible. It's usually what they use. But again, priority here is giving those antibiotics. And look, nutrition, high protein, absolutely. What does protein do? It aids in healing. And the other thing is these children are that pre-adolescent, when they're going to probably be home on bed rest in a PIC line. Remember, they also need some sort of psychosocial for being so locked up with themselves. I mean, we're lucky today with FaceTime, aren't we, with these kids? At least they can get out without going anywhere. Ewing sarcoma is mentioned because it's a cancer of bones. Any bone. It could be the jaw, it could be scapula, anything. We treat it cancer, radiation, chemo, maybe resection, depending on where it's at, right? And always cancer. If there's no metastasis, you do better. JIA, JRA, whatever, juvenile idiopathic arthritis. The body attacks its joints. In children, what do we see? Now, these are young kids, ages 1 to 3 is when we first start to see it. And many times they're like, oh no, the kid just fell down. He's going to be okay. Because remember, you're not always in pain. You're always maybe stiff. And stiffness is actually a little bit different. That's why they get undiagnosed. You need to know the symptoms of JIA. What are you going to see? Well, this is a kid, whether you're sitting down or in bed, not moving. When you get up, your joints are stiff. Actually, you have to stand for a second, stretch it out, and then slowly try to walk, because hips could be knees, could be hips, it could be ankles, toes, fingers, elbows, anything could be stiff. So you're going to see difficulty in walking, and because of this pain, a limp. Many people with rheumatoid or idiopathic arthritis get disfigurement of the hands, the feet, things, because the joints have been so affected. And the one thing students forget is uveitis. You can get eye damage, and you need to go to eye doctor minimum of once a year just to be sure and to check the eyes. The thing about rheumatoid arthritis is that it's extremely difficult to diagnose. I mean, I'm a nurse. I think I know what I'm talking about most of the time. It took them 8 years to diagnose me. I kept going back. There was no definitive test. It was, no, you're fibromyalgia. No, you're not RA. You're this, you're that. It's because it's such a, how do you figure it out? Well, it's a inflammation. So SED rates, will be elevated. Those inflammatory factors, white cells can be up. Your SED rates can be up. Another one is called a CRP, a C-reactive protein. That's going to be elevated. They do have a new test called a CCCP. And actually, that's the one that they finally listened to me and said, yeah, you do have rheumatoid arthritis. And I'm like, been telling you for a while. And of course, I went to 4 different doctors trying to have somebody listen. And the normal value was less than 50. I was greater than 250. So finally, diagnosis, they can treat and take care so that all the time I'm just not always in so much pain, because it stops the body from attacking myself. So, how do we treat it? Well, in flares, how do you treat inflammation? Corticosteroids. That is always your quick fix. We call it the Band-Aid for it, but it's not something to be used long term. NSAIDs, drug of choice for pain. NSAIDs, anti-inflammatory. Also, these maybe put them on some methotrexate. Maybe it is going onwards, putting them on some Humira. These children have to learn now to give their own injections, don't they? So that's something else there. Again, it's a long-term thing. Now, steroids started, Then they'll put them on methotrexate, sometimes orally, sometimes injections. Mine are injections. Then they'll put you on some sort of biologic, Humira as a start, and they go on until they find one that fits and one that works. And it could be the first one that works or the eighth one that works. So, how do we keep the body moving? Well, it's physical therapy, occupational therapy. For me, put me in a swimming pool and I'll stretch all the time. It's the best thing for me, and I'm weightless. Children, they love to get up and play and dance, all of these things. Stretching, keeping the body moving, is the best thing. Some children like heat when they hurt. Do not put heat on me. I like cold. Cold takes care of me. Heat makes me feel worse. So again, what do you like? Do you like heat? Do you like cold in one of those crises? Now, lupus is just like JIA, but the body attacks organs, any organ. The skin, that's those butterfly rashes, right? It could be brain, liver, kidney, heart, anything can do it. And just like JIA, triggers, it could be anything. Stress could trigger it. Lupus, sometimes they say the hormones because it's more women that'll be more affected. And again, it's that pre-adolescent area right there. And with lupus, one of the big things is be very careful with exposure to sunlight. Big thing with them. So you can have all of those, facial sort of skin and tegumentary problems, nausea, vomiting, diarrhea, weak, arthritis, joint. It's almost like JIA, with everything else that's going on. And it can go to the point of seizures, paralysis, pericarditis, and it can kill the kidneys and proteinuria. Again, any organ can attack. So again, goal is always supportive, whatever pharmacology. Most of the time, lupus children are on a low dose steroid every day, and sometimes Humira or something else, but usually, again, that's where they start. So, Kristen, 10 years of age, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that what? What do you know about an epiphyseal plate? What's the other name for it? Isn't that the growth plate? Epiphyseal plate is the growth plate. What do we know about growth plates and what's our concern? Bone growth can be affected by this fracture. You can have a crooked, short bone because it wasn't fixed correctly. So, neuromuscular, muscular skeletal. When we think of neuromuscular, you go right to CP, cerebral palsy. What is cerebral palsy? It's a permanent disordered with development and movement and postures, causing activity limitations. This is something that happened either intrautero or when they're born. They don't know all why. Some of the things we can predict, like hypoxia at birth, those things. But again, most common permanent physical disability in children. Many children with cerebral palsy are also epileptic. Why? Well, I said it could be a hypoxic episode. Yeah. Also, it could be something in the brain. The brain wasn't formed correctly. A lot of times it is low birth weight that can cause things from going on. Okay. And then I've actually seen children that can't get out vaginally, and then they have to quick run them into the OR, do a quick C-section. It's like they're pushing in this way and pulling out the other way. And we know the possibility of a hypoxic episode moment. Yeah, it's going to happen. And those children can, not always, can develop cerebral palsy. So any child who's at risk for it needs to be assessed. children in the newborn ICU all go through a bunch of monitoring to make sure that they don't have it. And if they do, what's the biggest thing with any cognitive delay on any child? It's early intervention, right? Physical, speech, occupational therapies. Now, spastic cerebral palsy is probably the type of cerebral palsy when you think of it, what you see. It's that hypertonicity, poor posture, and difficulty maintaining balance. These children need braces and they need sometimes wheelchairs, walkers, things to help them move and to be active the way they should. Now, we're going to see gross motor delays. They're not going to be able to up and walk by 1 year, maybe by 2 years, and maybe it's going to be in a wheelchair or not at all. Okay. You're going to see all weird different motions of the arms, normal postures. They're going to need to be buckled in when they sit down so they don't fall and roll out of places. These sort of things. Our goal with cerebral palsy is, we don't know how much, is in the brain if they can't talk. And there are a lot of nonverbal children with cerebral palsy. So our goal in that child is to give them the ability to be able to move around. I mean, that little picture shows you a lot. It's a little boy in a bicycle and he's moving, and you could tell he's cerebral palsy because he's got some braces on his legs, so he's able to move around, and he's a happy kid, right? Communicating. I was doing clinicals before we went COVID, and there was a little boy who I think he's 11 or 12 now. I'm shocked to think he's that old now, but he's cerebral palsy, spastic, cannot talk. But what they did is they gave him an iPad, and in that iPad, he can express his needs. In school, in speech, he was learning colors and shapes and letters. I mean, years ago, we didn't teach these children. We just took care of their basic needs. So this child was being taught. And again, let's teach them to their ability. And when they reach that goal, you're going to continue more. And the best thing is get them out with other children. They're going to have ankle braces, foot braces. They might need surgery. They might some sort of pharmacological. When you think of spasms, there's all sorts of drugs that can be used. Levodopa, carbidopa, used for Parkinson, that spasms. They're using this on cerebral palsy children, and trying to stop the tremors that go along with it. They're using Botox, all different things to try to give a chance for that child to be able to move and have a little bit of control. Another thing, dental hygiene. Remember, cerebral palsies, many of them have epilepsy, which means they're going to be on an anti-seizure medicine and possibly phenytoin, dilantin. Remember, that causes gingival hyperplasia. So good dental hygiene. And of course, therapy, speech, physical, occupational therapy are all needed. Now, most children with cerebral palsy can get up and move some way. Of course, there's going to be that portion who cannot. Our care on these children is they go home, they have parents and grandparents. It's to teach them all about giving physical therapy, occupational therapy, medications, keeping them safe, fall risk, keeping them talking and educating them and following through with whatever their school is doing for them. And again, it's hard to have a child with cerebral palsy, support that child. I had this little girl who was just aging out of pediatric daycare. I met her when she was 19 and nonverbal, cerebral palsy. And I noticed that she had these beautiful nails. So I came in one day with some nail polish and whatnot. And I asked the owner, can I paint her nails? She says, well, ask the mother. And if the mother is fine, that's fine with me. Well, I did. Every week I would go in, I would paint this little girl's fingernails. Well, she aged out and they had a party for her, and the mother came in, and I had made this little kit for her for, the nail files and whatnot for her, and it went home with her. And that little girl gave me a hug in the end. And so did the mother, but it was the girl. She recognized and she was going to miss me. Now, neural tube deficits. Remember in pharmacology, you learned about folic acid that prevents neural tube deficits? Was one of those things. Well, with neural tube deficits, what I want you to know is myelomeningocele, which means the meninges and spinal nerves are born on the side of the body, around at the lumbar area, so that the nerves are pulled up from the lower extremities and into the sac of that blob on the back. It's caused by many, different type of reasons that it could be caused by. It could be mom's maternal obesity, diabetes, or B12. But again, we know folic acid can help prevent it. So how are we going to manage? So you get this call, you're getting a baby, and they have a myelomeningocele. Well, our biggest concern, again, is infection. So we need sterile, normal saline and a dressing at the bedside. And they're going to put this nice, wet, sterile dressing on that back. And they're going to maintain the integrity of the skin so that when we can get it put back in, it'll be clean. It's not going to be infected. What do we have to watch in that child because of that? Well, this is a kid that you're going to be placing on their tummy. They can't go on their back, they can't be swaddled. You have to monitor it. They'll be in a warmer, okay? Their lower extremities is probably going to have decreased sensation and strength. Are they going to have bowel control or urine control? These are things that must be monitored very, very closely. And that's what I told you, folic acid, it's preventing. All right, let's go into some of those muscular dystrophies. Floppy infant syndrome, Wertning-Hoffmann's disease, progressive wasting, and they usually die before they're 2. It's all of a sudden babies are born and they don't have any muscle strength, and that's normal, right? Well, about 2 or 3 months old, they're supposed to be able to lift their head at least. Well, they're not doing it. Also, you're going to see this child in this frog position, arms up, legs up, and that's normal. They have no strength. You're going to see a very weak cough. And that's this Werning-Hoffmann's disease. Now, the one muscular dystrophy that you will see on Hesse's and Kleck's, this is the one they like to pick on, is Duchenne muscular dystrophy. It's from the X-link, which means mommy gives this to the child. This is a boy, ages 3 to 7. So you're going to see an infant born, and they're going to slightly delayed, but go through the development the way they should. And then you're all of a sudden going to see these very hypertrophic calf muscles. So it looks like they're over exercised their legs, calf muscles. But all of a sudden, this kid was walking. Now they're going to start going backwards. They're going to start falling down. And now this is all about muscles dystrophy, muscles becoming not working right. That's what that means. So it worked right, and now we stop. What are muscles in the body? Well, remember the diaphragm's a muscle, so that's going to stop probably in the teenage area. And the heart's a muscle, and that's what they usually die from. These children, what you'll see is, you can imagine having a kid who's fine and all of a sudden starts falling down, getting worse and worse, and take them to the doctor. And the test that they do to look at muscle and muscle strength is something called electromyography, an EMG. I had one many, many years ago. They take these little probes or needles and put them areas, arms, legs, whatever they want to do, and they put a little burst of electricity and your arm or your finger, it moves. And if it is a nerve that hurts, it could be a little bit painful. Now, with these children, they look at their muscles, they look at reaction time. When they come back from these procedures, it's like they have just done a marathon. They have really spasmed every muscle. So make sure they get some Tylenol, acetaminophen, or ibuprofen, something, because they will be have some discomfort, but it's not going to stay. It will go away. It's temporary. Another thing, I said they're falling, right? So what they're doing is they're waddling back and forth, planting their feet so they don't fall. And then, like I do, if I get on the floor, I can't get up. So you're going to take and put your arms and crawl up your legs and sit yourself up. That's Gower sign. This child also, lordosis, lumbar spine is curved in backwards. You're also going to see those enlarged muscles on the thighs, yes, but also it could also be on the upper arms also. These children do have some mental impairment from mild. That's the one that's harder to even anticipate. It could be something else going on to absolutely, moderate and more. And because of lack of muscle and movement, they're going to be a little bit bigger. They're going to be a little bit obese. So what is our goal? Well, there's no treatment. Really, I mean, it's just all supportive again. There's no cure for this. Genetic counseling for this family is imperative. Mom needs to know that it came from it's that X-link thing that gave this child Duchenne muscular dystrophy. And does she want to have another baby? That would be a decision that she'd have to know. These children, again, muscles aren't working, so we need to work them for them, range of motion, bracing, keeping them up and moving is very, very, very important. Now, another condition with nerves is called Guillain-Barré. Guillain-Barré is when nerves stop working, starting in the feet, and it goes up the body, and the nerve that we're most concerned about and monitor very closely is the phrenic nerve, which means phrenic nerve becomes paralyzed. You don't breathe. So what do you think we're going to do to monitor this child? Well, this child, you're going to see that tenderness, that numb, weak legs that are going on. And it starts from the feet, ascending up to the diaphragm, okay? You might see all of a sudden this child starting being incontinent where they haven't been in a long time, or they're constipated, and that's just not normal. It means those nerves aren't working down there. So again, symptomatic, but we're going to be monitoring their respiratory effort. This is your whole goal here. You have a child suspected Guillain-Barré. They're going to start becoming numb from their feet working up. You're going to monitor bowel and urine, and you're going to be monitoring their oxygen saturations and their respiratory status. So in case they stop breathing, you're there and you could offer respiratory support. I worked with a nurse who she was 20 something, which is a little older. She was a supervisor, and she ended up with Guillain-Barré and was admitted to the hospital where she worked. And I watched her whole progress. She was in the ICU for about a month, and then all of a sudden, she was, of course, on the ventilator. And then all of a sudden, you start to see her taking breaths over the ventilator. So you knew now she was breathing. And they finally got it off, sent her to rehab because she was so weak by the time she was done. And she did well. Tetanus, stepping on a rusty nail. Well, tetanus is all about the jaw and the airway. Lockjaw, neck rigidity, and the masseter and neck muscles, anything that chews, anything in here. So can you imagine progressive stiffness and tightness? And then it goes into facial spasms, okay? You're going to see all of the muscles tense up in body, arching legs, respiratory, it's going to tetany, it's not going to work, not going to breathe. And how do we treat this? Well, these children are sick, sick, sick. If we can diagnose them quick enough and get them the tetanus tox vaccine is what they need in order to help them. And as nurses, we're monitoring respiratory status. We're making sure that they're breathing and that the airways are clear, and getting their tetanus toxoid. So if we get a child who, like, there's a little boo-boo on the foot, like I tell you, they always get them there. How do we treat them? Now, I've seen it treated different ways, but many times they'll even take the tetanus antitoxin and inject it around the wound. I've seen animal bites where they've put it around a wound. I've seen raccoons and birds of all types biting children, but putting really nasty bites. And they do give them the tetanus vaccine. Now, they put it around and give them the immunoglobulin. And then there's a couple more in a series that they do give for this. So these children in the hospital monitor their respiratory status. Now, of course, intake output, daily weights, you don't want to overfluid them, right? Monitor electrolytes. And of course, the tetanus immune globulin therapy as it is ordered. Don't forget that there's a boo-boo on the foot. You need to clean it and put an antibiotic ointment on it, right? And because of the severity of muscle spasms, they put this child on muscle relaxant. This is what they use when they put you to sleep to go to the OR. So muscle relaxants, you can't move a body. But again, it's not spasming. You can't feel it. But remember, they're wide awake. They need sedation with that. You can paralyze, but they're awake. So make sure that they have something to knock them out a little bit. Another thing is botulism. This is when grandma says, oh, they're constipated, give them a little bit of honey and they'll feel better and they'll move their stools. Well, the problem is honey, caro syrup, those things, we don't know how clean it is. Is it, was it bought on the roadside or in the grocery store? Was it properly stored? It really, really is high risk for botulism. So it should not be given to children less than 1 year old. Never. It's basically all central nervous system where all of a sudden you're weak, you're dizzy, headaches, you can't talk, you vomit, and then it's another respiratory, stop breathing. So again, giving the botulism immunoglobulin, monitoring respiratory support, and anytime child sick a long time, nutritional support. And then spinal cord injuries. That's the picture of that little boy, angulated 5/6 fracture. The one on the right. You see how it angles? That was that poor little boy. And thank God today he's out and running around and makes me happy. Why? Motor vehicle, sports, birth. Think about that. You're pulling a head out, right? Non-accidental trauma, which means abuse. And then getting in a car, hyperflexion, hyperextension, head back and forth can cause those injuries too. So, what is your goal? What was my goal for that little boy with that neck injury due to sports? Number one, I'm monitoring that head. I'm monitoring that neck. I don't care what else happens. You leave my head and neck alone. I am in charge. I don't want anything to happen. And it's that stabilization. It was that putting on the collar, taping them to the backboard. That's what all helped them. Okay. And again, this is not just me. Again, this child does have weakness. It's going to be multidisciplinary. This is everybody, nutrition, physical, occupational therapy, everybody taking care of that kid. So do you remember which one was the infantile spinal muscular dystrophy? The floppy one? Oh, it's number C, Werding Hoffman. A lot of interesting stuff, huh? Any questions? Who wants to win a Kahoot today? Oh, Dailies wants to, and Yasmin, I see you there. Who else? Alberto, you're going to win today? Oh, Carol Ann, there you go. I'm going to call you Carol Ann. I don't know, I like that name. Yeah. And as soon as we're done with the Kahoots, that will be class. Probably be done about 5 after, I would imagine. So it's a good class for y'all. Everybody who wants to come in is in. Oh, we got a real fight tonight. I like it. Let's go for it. Week 9. I'm just amazed it's week 9 already. 44 questions. What is a priority for a nurse to assess following a cast application? Priority. So when we're looking at a cast being put on, isn't it all about those 6 Ps? Pulses, pain, movement, sensation, pressure, all of those things. Sigh. Patient teaching for a child with a fractured bone that has had a new cast applied. Hmm. So you don't want to put powder or anything in there. It gets caked up in there and that can create problems. And a cool hair dryer is really good. It does work. What should the nurse monitor after a soft tissue injury? Like an ecchymotic area, right? Big bruise. So, I mean, it doesn't look like it's that bad on the outside, right? On this picture, but is it inside, occluding any pressure, right? So never be fooled by these things. Always go and look for the neurovascular signs. More important than just regular vital signs. A fracture that penetrates the skin is called what? It's called a compound. Simple as when it's not closed. By Bryant's traction. So it is used for children less than 30 pounds. That's the one thing that you need to know. The child cannot be greater than that. It is for your hip dysplasia. The hips are higher and less at a right angle. And yes, always with any sort of traction device, whether it's the Bryant's or whether it's the Pavlik harness, always check for skin breakdown. What is the priority nursing care of a child with a compound fracture? Compound fracture. That's a fracture where the skin is open and the bone is broken. Priority is IV antibiotics. Now, all the other stuff needs to be done, of course, but you need to keep that infection from spreading. What is a priority nursing care for a child who fell off a second floor balcony? I've seen this happen 3 times. They have a chair out there and a table, and this young kid gets on top and they fall off. So you have a kid fell off, they're on the ground. Your priority is to immobilize the spine, whether or not you think that it's displaced or not. It's better to be safe than sorry. Principles of managing soft tissue injuries include so it's rice, rest, ice, compress, and elevate. And physioplate fractures in children may do what? So an epiphysioplate is your growth fracture. So if we have a fracture there, you're worried about bone growth. Very good. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? So an impairment neurovascular is no pulses. That is absolutely that. And the other one would be, very decreased pulses as compared to another extremity. Yes, but absent. Okay. How should the nurse care for the skeletal traction for a child with a fractured femur? So you have a child, fractured femur, and they're on bucks traction. What's our thing? How do we take care of it? Remember, the fractured femur, we pull it into place, it's being pulled. There's a pulley and a rope, and there's a little weight that hangs off the end. Well, the thing is, we leave it on, never touch it. We need to document what is the weight on there so that it shows, because people will come and they'll take things off. Kids will come and pull off weights, or something happens. Make sure you document the weight and that it's always there and it's hanging freely. Never ever change the weights, never remove them. Because what if you have a fractured femur and it's really in good position? You remove the weights, guess what? You're going to go back to those bones sticking up into the muscles and muscle spasms. When caring for a 9-year-old in bucks traction, what action by the nurse is correct? So this whole thing is just checking capillary refill. You're not going to place the weights anywhere. You're not going to show anybody to raise or lower a bed. And you're not going to have anybody sitting on the bed because that can hurt, that jostling. What position do you put the legs of an infant with hip dysplasia? It's called abduction. Okay. They need to be abducted in order for those hips to go into the socket and stay there. What statement by parents indicate more teachings regarding their 2-week old infant with club feet? And those are club feet, and those are actually the quite severe ones. They can be a little or they could be a lot. That one is quite a bit. Remember, 2 weeks old. Remember neonates. Remember bone healing. You want to get that baby in there as soon as possible and get the cast starting weekly, right? And if they say they want to bring it in a month, it's not going to heal properly because they're healing so quickly now that it's going to heal improper. Very good. Another multi. Osteogenesis imperfecta, OI. I was watching a documentary on parents who had a little baby with OI, and they thought that this child was child abuse until they found, and they almost going to jail for it until they found out it was OI. Believe it or not, that did happen. It is brittle bones. For what, why, it's not really understood, but they're crooked and they crack very easily. As a nurse taking care of these children, can you imagine baby changing a diaper, even trying to lift them up? They're that brittle. What is the pathologic cause of leg calf birth disease? Remember, leg calf birth is the head of the femur. It gets necrotic, but there's no infection. So it's an ischemic, aseptic necrosis of the femoral head. Treatment, bed rest, NSAIDs, and maybe some traction. Phosis. So kyphosis is also called humpback. It's the upper one that you sort of lean over with. Well, they're multi. Which assessment indicates an infant has developmental dysplasia of the hip? That hip and that femoral sock is just not in the right place, somewhere up here. What would you see? You're going to see that the buttocks folds, one's up, one's down. One leg is longer than the other. And then positive ortolani, you're going to hear clicking going on. Moro is startle reflex. Babinski, all age children and adults have it. It's where you do the bottom of the foot and your foot splays. Lordosis is described as what? Well, we know Duchenne children have lordosis, right? It's that inward curve of the lumbar spine. It's in like that, and they sort of lean backwards. Scoliosis is scoliosis is where the spine is just this absolute S. Again, one shoulder's down, one hip is up, and it's very visible. Again, treat 23 hours a day, cotton shirt, brace on, physical therapy. An adolescent with scoliosis have up to a 45% of the curvature would need to do what? Up to 45. It's the after 45 that's the trouble, right? So this is the one that we can do a brace. When they ask you questions on these on the exams, you're going to say 50, 55%. It's an extremely obvious thing because if you can imagine, you think about scoliosis, you've got a curve, and this is where your lungs are sitting. And if it's curved, this lung is being squished, but so is the other side. So the respiratory status is a big deal to get that spine back less curved. A multi. Teaching for a child with scoliosis with a less than 40 degrees of curvature. So wear that brace 23 hours a day, that cotton shirt, keep it from rubbing in there. No lotion, it just builds up. And again, physical therapy, the exercises, strengthening the muscles is what helps that curve. Multi. A Pavlik harness. You have that picture that you can remember with that little kid, little baby with those arms, those legs pulled up, right? They're all abducted. And again, on infants for developmental dysplasia of the hip, it holds it into abduction. You should always check the skin, and then you should massage underneath the brace just to make sure there's no rubbing going on there. Again, 23 hours a day. What is osteomyelitis? So osteomyelitis is an infection, inflammatory condition of the bones, and it could be any bone. Goals of JIA include so JIA is all about the body attacking its own joints. So our goal is to reduce the pain, reduce the swelling, and stop the body from attacking it. A multi. What might you anticipate for a child diagnosed with JIA? As part of your assessment, these are things you're going to be looking for. So facial rest is lupus. Very good. You didn't fall in that rabbit hole. Joint disfigurement, difficulty walking, that uveitis, absolutely. What is cerebral palsy? So cerebral palsy is all about the inability for you to move your body normally. It's just all this um, muscle coordination is just not there, and it's spastic, and it can't be controlled. A multi. The signs and symptoms of spastic cerebral palsy. We really think when we think cerebral palsy, we think of the spastic. We don't think of the minor cerebral palsies. These children, they are poor posture. They have really poor bimotor skills. Gross motor they can work with, but not as much that little fine little thing. Also, they're hypertonic, the hypertonicity, and then they have problems with balance. So they need a walker or something to assist them with ambulation. Bye. When feeding a child with cerebral palsy, what's important to remember? So remember, cerebral palsy is all about muscle coordination. You use muscles when you eat, right? So what do you have to remember knowing that? Keep the head of the bed elevated. Thick liquids are better. They have less chances of aspiration on thick ones. And of course, give that child extra time to chew and to swallow. Sometimes you have to help with their jaw too to help them move and to chew and to chomp the way they should. They don't need just gastrostomy tube feedings. They need to sometimes supplement with it to make sure they get plenty of nutrition, but it's not going to be only a myelomeningocele. What do we know about a myelomeningocele? When the meninges, spinal cord, and the nerves are pulled from the bottom up and are on the outside of the body at that lumbar area. It's a hernia. Spinal cord, meninges, and the nerves that are part of that spinal cord. A multi. What can help a child with lupus prevent exacerbations? Well, these exacerbations can be caused by stress and hormones and infections. But the other thing is all about sun, preparing by being putting sunscreen on and decreasing the quantity of time that you're out there. Also, just like JIA, does you're immunosuppressed, making sure that they get a prophylactic antibiotic or steroid like before procedures, as in dental extractions. Infants with a myelomeningocele demonstrate what? Remember, the nerves, spinal cord are pulled up, and the meninges on the outside of the body from the bottom. They're torn, as I call it, like ripped up out of the bottom and pulled up. So, because of that, it's motory and sensory. Okay, the nerves you're going to have decrease if it's been ripped up there, and of course, nerves have to move, so it's motor and sensory. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? What are you concerned about if your lower extremities have had their nerves ripped up and you have decreased sensation? So, urinary retention. Sometimes these children require every 4-hour catheterizations for life. And actually, as they get older, they learn how to do it themselves. Some of them we can just push on the abdomens and they go, and some are not affected. Every child is different there. But urinary retention, and you also have to worry out for bowel movements, making sure they're not constipated. A key feature of Duchenne muscular dystrophy is there's your whole big picture there about it. Remember, Duchenne muscular dystrophy is a child around ages 3 to 7 male who all of a sudden their muscles tend to get weaker, progressively worse and worse. And it ends up their heart or their diaphragm stop working, and usually as a teenager is when they die. What is one of the procedures that a child with possible Duchenne's may need to diagnose their condition? Remember, Duchenne is all about muscle weakness. So let's see how weak you are. Let's see the strength. Let's see how quickly your body responds to this little electrical impulse. It's called the EMG. And remember, nursing, you need to think about that child when they come back from this procedure. It is like they have ran a marathon. Make sure they get some acetaminophen, ibuprofen, something. Their muscles are going to hurt, and probably for a couple days. How is Duchenne muscular dystrophy inherited? This is one of those conditions that if parents want another child, genetics must be done for them. And it's X-linked. It comes from mommy. And can you imagine the amount of guilt mommy feels that they had this baby, this boy, and now it's Duchenne muscular dystrophy? And what if they want another child? That's a decision that's very difficult to make. In caring for a patient with Guillain-Barré, the priority concern is what? Guillain-Barré is a virus, probably after an upper respiratory, like a couple weeks ago. And it's a virus, so Epstein-Barr virus type thing. And it's something that you don't treat with antibiotics. You basically monitor them and give IVIG to these patients. And hopefully that these patients don't get to the point where it hits their diaphragm. Because remember, Guillain-Barré, you start shuffling, then it moves up, then you might feel some problems with urinating or defecating, and then it goes up into your lungs. So again, monitoring the airway, but you can actually watch it as it progresses upwards, that ascending thing. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? So this is ascending, which means it starts from the feet and works up. And then after the nerves start coming back, it's descending, and all the nerves start functioning, going descending from up to down. Say, treatment for Guillain-Barré. So Guillain-Barré is a virus, so antibiotics aren't going to work. Heparin is not the treatment for Guillain-Barré, although I won't say that it may not be giving prophylactically to prevent clots because they are paralyzed, maybe. But the treatment is IVIG and respiratory support. Keep the lungs moving and then boost the immune system through intravenous immunoglobulins. What type of cerebral palsy causes hypertonicity and poor fine motor skills? So this hypertonicity, when we talk about cerebral palsy, that is your spastic. That's the one that's the obvious one. And I know it's what I think of when I think of CP. What priority action should a nurse take to a patient with a suspected spinal cord injury? And your priority, number one, is immobilization of the spine, trying to prevent any sort of neurological deficits like I did for that little boy. You should get a tetanus shot every what years? I remember every year, and then I remember every 2 years, and then I remember every 5 years, and today, 10 years. So I've watched the evolution of it all. And now they're doing tetanus with diphtheria. They're doing them both together. What is a symptom of tetanus? And that's lockjaw. Remember, tetanus is all about all of this getting swollen, and this is severe, severe muscle spasms. And it's painful, and the spasms choke them, and they can't breathe. So we treat this with your antitoxin for tetanus. We treat them with respiratory, ventilators, whatever. And of course, muscle relaxants, really powerful ones so they don't feel all the pain. And last question. Common causes of spinal cord injuries are what? It's motor vehicles, driving, sports. I mean, these are the big things with those injuries. Let's see how we did today. Cindy. Good job, Cindy. Number two, MJJJJ. Good job. And number one, CJ. It's the name of my grandson, CJ. And Val and me. So we are done with week 9. We did really good in time today. Um, remember, anybody who's getting their reports back for their projects, if you want to get a better grade, you must get it in as soon as you can. All right. And I give you that better grade because I believe this is a project of learning. As you, many of you want to go on with your education. So it is there to help you. And Dr. Brown knows I do it. So we can do it without a problem. If you see any messages, please answer them and get them done. Remember, I'm doing my review on Thursday. I'll be doing it at 2 o'clock. And anybody who wants to meet with me, please make an appointment. I would love to. Just send a message in Canvas and I will get back to you. Any questions?
Yes, when we get our project back, it'll tell you